and welcome to our diagnostic presentation. I want to start with a brief case summary. The client is a 24-year-old Navajo male, and he was self-referred for the following concerns: grief and sadness regarding the death of his father and his uncle, past family problems, self-esteem issues, a history of sexual abuse when the client was 10 years old by an older boy, anxiety, and health problems. The presenting symptoms with this case are grief, sadness, poor self-esteem, anxiety, shame, anger, and depression. He also displays crying spells, feelings of emptiness. His somatic concerns include headaches and stomach pain. He is also experiencing unintended weight loss, stress, and insomnia that is recurrent and is no longer responding to past methods to alleviate that. His academic history is also very inconsistent. He has switched back and forth between school and working and has recently decided to leave school again. In addition to that, his academic performance is also inconsistent. There have been periods of time where he's performed well, and then periods of time, such as recently, where he is not performing as well. The client also has a history of sexual abuse when he was 10 years old, which has led him to have no other sexual relationships or encounters. So that is something that is worth considering when looking at this case and considering diagnoses. The client is also becoming socially withdrawn from his relatives, who he previously had a good relationship with. And several years ago, his father died, which is a very large focus of this case because it seems that a lot of these symptoms onset after the death of his father. The most likely diagnosis that we have settled on is major depression with comorbid PTSD. This is because of those symptoms here, the unintended weight loss and frequent crying, which are related to both PTSD and depression. He is socially withdrawn and is experiencing prolonged grief. We think that the prolonged grief is related to PTSD in this case. He has experienced a traumatic event in the death of his father and the previous sexual abuse in his childhood. The client also reports that he is abusing substances. He uses a hallucinogenic drug on occasion. He smokes marijuana on a weekly basis, and he drinks alcohol on a regular basis. He also reports that he has been having a higher tolerance to alcohol and has experienced one instance of blacking out. He's also experiencing sleep disturbances, so he has experienced insomnia before, but was able to alleviate it and get to sleep with several different methods. However, those methods no longer work for him, so this indicates that it could be related to the diagnosis of depression and PTSD. He's also experiencing headaches and stomach aches and feelings of emptiness, hopelessness, and shame. An alternative diagnosis that we considered was adjustment disorder, and these are some of the symptoms for adjustment disorder. So a depressed mood, insomnia, feelings of worthlessness or inappropriate guilt, weight loss, loss of interest or pleasures, and tearfulness. Adjustment disorder is also something that occurs in response to a stressor. So the stressor that we considered here would be the death of the client's father, which appears to be the catalyst to a lot of the symptoms that he's experiencing. However, this is not the diagnosis because while adjustment disorder mirrors depression, adjustment disorder only persists for a short amount of time, so no more than 6 months. The client does appear to be suffering from situational depression due to the stressor of his father's death and his past trauma, but it has persisted for longer than 6 months. So therefore, the situation is better explained by major depressive disorder. So adjustment disorder can be accompanied by any other mental disorder or medical disorders as long as all of the criteria has been met for the diagnosis. It's commonly diagnosed with anxiety, depression, or both of those disorders. A second alternative diagnosis that we considered was alcohol use disorder. Some of the criteria for this disorder are the use of alcohol over a long period of time, lack of control over the individual's alcohol use, recurring alcohol use, increased intolerance to alcohol, and instances of blackout. However, we're not sure if the client has ever attempted to quit drinking or even wants to or has any difficulty in doing so. So that is a missing piece to the puzzle for this diagnosis. So this is not our main diagnosis because we are unsure of his efforts to cut down or control his alcohol use. We also suspect that he may be using the substances to self-medicate. This could possibly be a provisional diagnosis. However, the patterns may change as he finds better coping skills. And again, we're unsure of whether or not the criteria are truly being met here. So while he does meet some of the criteria, such as blacking out, we only know of one instance of a blackout, and this was very recent. He also has very recently began building alcohol tolerance, so it's unclear whether or not he meets the severity of the symptoms to conclude this diagnosis. All right, so some of the comorbidities associated with alcohol use disorder is that a lot of mental health issues contribute to substance use disorders because clients try to use alcohol or other drugs to control their depression. About 50% of individuals with a severe mental disorder are also affected by substance use, so it's highly comorbid with mental disorders of all kinds. The third possible diagnosis that we considered was persistent complex bereavement disorder. So some of the symptoms that we see in this case that coincide with this disorder are a diminished sense of self, and we believe that this is present because he continues to make changes in his life, such as going back and forth between school and work. He is having difficulty with moving on from the loss of his father. He is very sad about the loss of his father and has a lot of dreams about his father. They're not described as nightmares. He just sees his father in his dreams. So this might indicate that he's yearning for the lost person. We suspect that he also might be experiencing an inability to trust other people as he has become really socially withdrawn. And to kind of go off of that, we suspect that he might be avoiding reminders of his father by withdrawing from his family members. This is not the main diagnosis because he does not display enough symptoms to meet the full criteria. It's also debatable whether the symptoms are actually present. We would need to conduct more clinical observations to determine whether or not they are actually there. So therefore, we believe that the disturbance in mood is better accounted for by MDD. So persistent and complex bereavement disorder most often is comorbid with major depressive disorder, PTSD, and substance use disorders. This makes a lot of sense, especially with this case. A lot of the symptoms of those disorders overlap, and the client does show some symptoms within the criteria for this disorder, and the above-mentioned disorders have also been considered for his diagnosis. So there's quite a bit of additional information that we would need to get in order to make a more full diagnosis. Firstly, an important factor is that the client is Native American, and historically they have been oppressed, and research suggests that this may have resulted in intergenerational trauma. It might be beneficial to ask more in-depth questions about the client's family history that could better explain some of his disturbances in mood. We would also want to administer a depression assessment such as the PHQ-9 to determine the severity of his symptoms to make a more clear diagnosis. It also might be useful to identify client strengths and goals. He stated that he has a large extended kinship network, but it would be nice to know what other resources, internal or external, that he has that he might use to achieve his goals. It's also interesting to note that he does have a history of sexual trauma, which was very briefly touched on in the case vignette, and that is also some more information that we need, especially to assess symptoms of PTSD and to explore some of his shame and guilt and the sense of identity that he might lack in that he doesn't really identify with sexuality or romantic relationships and things like that. So to kind of overview the course of the illness, according to the DSM, 2 in 5 individuals with MDD will recover after 3 months, and 4 in 5 will begin to recover within a year. However, our client reports having symptoms that have persisted for longer than a year, so this might be indicative of the severity of his symptoms and his diagnosis. Adverse childhood experiences, such as his sexual abuse history, increase the risk of experiencing symptoms of MDD. Stressful life events are also correlated with the onset of MDD. The DSM-5 also states that there is a genetic component of MDD. While the client denies mental health issues in his family, the intergenerational trauma and other factors unique to Native Americans may be relevant to the case. In the study of 306 American Indian adults, over half indicated that they thought about historical losses at least occasionally, and that it caused them distress. So thoughts of historical losses and their associated symptomology are common, and the presences of these thoughts are associated with Native American heritage, cultural identification, and substance dependence. So this kind of leads into some cultural considerations as well that are important to this case. So I did mention before that he uses a hallucinogenic drug on occasion. That is part of Native American culture. The drug is called peyote, and it is tied into religious beliefs. Peyote is protected for religious use for the Native American Church under the Indian Religious Freedom Act of 1978, also known as the American Indian Religious Freedom Act. Since peyote is part of Native American religions, we should respect the client's autonomy with respect to their culture and beliefs per the NASW Code of Ethics under dignity and worth of the person. It states that social workers treat each person in a caring and respectful fashion, mindful of individual differences and cultural and ethnic diversity. So, more in cultural considerations are that Native Americans have unique risk factors. As I mentioned before, they have been historically marginalized in the U.S. This has taken place through forced marches, forced assimilation, and other forms of oppression committed against this population. This may be linked to what researchers describe as intergenerational trauma. Native Americans also have higher rates of substance use, PTSD, and suicidality. They are 56% more likely to die from alcoholism, and 1 in 8 Native Americans adults need treatment for substance use disorders. Researchers have also found that with some regional exceptions, American Indians have high prevalence estimates of tobacco use, obesity, and physical activity, and low prevalence estimates of fruit and vegetable consumption, cancer screening, and seatbelt use. This is further evidence of unique adversities faced by the people of Native American descent. As a result, this information should be taken into consideration while working with this client. So overall, we decided that this client most likely has a diagnosis of major depression disorder and PTSD. Further considerations with screeners and getting more in depth into his symptoms and where they're coming from is needed to make a more solid diagnosis. But with the information that we have currently, that seems to be the most likely. So here are our references. All right, thank you.